technical difficulties can get you. I actually had my internet go down at like 10. So I was on the phone call with Midco. There was like a huge outage, I guess. So it always happens on those days.
Of course it would. Yeah.
For everyone hopping on, we are going to start in probably about 3 minutes. We are just waiting. There were some technical difficulties with our presenter, and so it will just be a few more minutes. Thanks, everyone. I see we're at 43 attendees so far. And if you just hopped on, we are waiting for our presenter. He was having some technical difficulties, so he should be joining shortly. Thank you for your patience. Hello.
Hello.
Got everything taken care of on your end?
Yep, I'm sweating a little bit, but I got it taken care of. Sorry about that.
That's okay. It's just fine. All right, so we are recording and I will share my screen. Everything look okay on your end, Dr. Steig? You can see this?
Yep.
Okay.
I just will prompt you when to go to the next slide when I'm giving my.
I can have you share your screen.
Oh, that works too. Yep, perfect.
Okay. Beautiful. Okay, thanks everyone for your patience and welcome to our webinar Lunch and Learn about preventing shingles. My name is Mary Lizakowski and I'm a Coalition Health Director with the Foundation for a Healthy North Dakota. It is a newly established nonprofit in North Dakota. We are comprised of a small team. Our mission is to promote health and wellness by working at the community level across North Dakota. We are building a statewide coalition to allow local communities to collaborate and work together on common initiatives. And by joining the coalition, members will be first to know about educational opportunities such as this, the latest on relevant public health information, legislative updates, and access to digital advocacy resources and toolkits. Just some housekeeping things to go over. Webinar attendees will be automatically muted for the presentation. If you have questions, please put them in the Q&A box. Our team will be monitoring questions that may come in. We will be recording this presentation and we'll leave time at the end to address any questions you may have, along with questions that came in during registration. After the presentation, links to the recording will be sent out along with an evaluation survey to complete. Now it is my pleasure to introduce our presenters today. Dr. Jayme Steig, he is a pharmacist and faculty member in the Department of Pharmacy practice at North Dakota State University. Throughout his career, Dr. Steig has supported multiple projects to increase immunization rates by directly providing vaccines and helping others implement best practices. He has experience in quality improvement, community pharmacy, and medication therapy management. And next we have Beverly Torgerson. She is a retired high school teacher, English teacher, and speech coach from Warren, Minnesota. She and her husband, who is still actively farming, are the third generation to live in their century-old family farmhouse. She is an avid reader and enjoys needlework of all kinds, including weaving and knitting. Her latest two goals are to learn rosemalling and spinning yarn. Spending time at the lake with her 7 grandchildren gives her great joy. She will be sharing her experience with having shingles. Thank you both for being here today, and I will turn it over to Dr. Steig to give his presentation. So I will stop sharing and you should be able to share. Looks good.
Okay, hello everyone. I hope you can see my screen.
Yes.
Okay, wonderful. Well, thank you all for attending today. Apologize for getting off to a little bit of a late start. Technical issues working from home. Sorry about that, everyone. I look forward to our discussion today on shingles. Please feel free to ask questions as we go along, and I'll do my best here to answer them. Here are some of the questions we're going to try to answer during today's webinar. So keep these in mind as we move along. Those questions are, what is shingles and who's most likely to develop it? How can that risk be reduced? What vaccines are available for shingles and who should get that? And then we'll look a little bit about how we're doing as far as getting people vaccinated for shingles. And finally, talk about how we can get more people vaccinated. So let's get started here. So what is shingles? Well, shingles is caused by reactivation of the chickenpox virus, or also known as varicella zoster. More than 99% of Americans born on or before 1980 have had chickenpox. Even if they don't remember having the disease, more than likely they have had it. After we've had the chickenpox, some of the virus that causes the chickenpox can remain dormant in our bodies. It's still present in our bodies, but it's not causing active infection or symptoms. The virus may never cause symptoms again, or unfortunately, it can reactivate many years later. And when it reactivates is when we get shingles. Where we see how it works is that the vaccine stays dormant in our nerve cells, kind of our branches that branches off from our spinal column. And so we see reactivation along that spinal column that can lead to patchy rashes in kind of a lateral pattern across our bodies. We're not completely sure of the reasons why the virus reactivates, but we often associate it with weakened immune systems from other conditions or drugs that suppress the immune system. The virus does create sores and rash similar to that with chickenpox. Symptoms usually begin with pain and some tingling along those affective nerve bundles. And that's preceded a couple of days later by the development of the rash and the zoster shingles blisters. This outbreak almost always appears as a strip of skin over the affective nerve fibers on one side of the body. And the sores may also spread just a little bit to the surrounding area as well. These sores can be very painful. They typically dry and form a scab about 5 to 10 days after they appear. Now, until the blisters scab over, they are contagious and contain varicella virus, which, if spread to susceptible people, can cause chickenpox. So you want to be careful if you have someone with shingles and you have them around someone who hasn't had the chickenpox or someone that's susceptible, to not expose them. You cannot get shingles from someone that has shingles because the shingles is based on the reactivation of virus that's already in our body. And then once those scabs clear over, in about another week or so is usually when we see things fully clearing. So who gets shingles? In the United States, about 1 out of every 3 people will develop shingles in their lifetime. It can occur at any age. However, we see the risk increasing with advancing age due to our immune systems weakening as we get older. About 50% of people who live to the age of 85 will have experienced shingles at one point in time, which is demonstrated here on this graph. We see the rate increasing with age. This is often a one-time issue. Most people just develop shingles once. However, 4% or just a little bit less than 1 in 20 people that get shingles will redevelop it again. And then, so with that increasing age, and the risk increasing with age, we need to consider that in North Dakota, 20% of our population is age 60 or older. So we are in a state that has an older population, which means we have a greater percentage of our population at higher risk of developing shingles. And some people have greater risks. This includes people who have medical conditions that keep their immune systems working properly, such as certain cancers, HIV, and those that receive drugs to keep their immune systems from working at full strength, such as steroids and drugs that are given for organ transplantation. Those are some examples of people who also have a risk of developing shingles. And then, of course, the final risk factor is that you've had chickenpox. Anyone that's had chickenpox is at risk for developing shingles. Well, the pain and rash that comes with active shingles is reason enough to want to prevent it. There's another long-term complication with shingles that we need to be aware of. Occasionally, the nerves involved can include the nerves that lead to the eye and the ear. So sometimes we can see some problems with that. And in those cases, obviously some complications from that. We can get the blisters can cause some scarring, which leads to some cosmetic issues. But the most common complication of shingles that we're worried about is postherpetic neuralgia. And what this is it develops in about 10% of people who have had shingles, and it is most common among older people. So again, the risk of developing this complication increases as we get older. And what's involved with this is that people who have had shingles continue to have pain long after the rash has gone away. So the rash goes away, but that pain and that burning sensation may remain. The pain occurs in the areas of the skin that were supplied by the nerves infected with the shingles virus. This condition can last for weeks, months, or in some people, it can be a chronic condition that they always have to deal with. In most, though, we see it going away in about 3 months. But again, it's not an enjoyable situation to be in. The pain can be very severe and disruptive to people's daily routines. The pain also for that long term, 1 in 5 people can experience pain for longer than a year. I skipped the slide here. How do we treat shingles? Our treatment depends on the clinical situation that the person has. Someone with an active case of the shingles, a lot of times they don't get any treatment, and the blisters and that will heal over on their own as the infection runs its course. However, for those with risk factors, including being over the age of 50, or having susceptible immune systems, or experiencing severe symptoms like really painful and severe blistering, we can treat those with antiviral medications. While they do not cure the disease, they can help relieve the symptoms, shorten the symptom duration, and decrease the chance of complications. Most often we're using oral antivirals like valacyclovir or famciclovir. And what's important here is that we need to make sure that we start those within 3 days of the development of that rash. If it goes out past that, we're not going to see much benefit from this treatment. For individuals that are experiencing that postherpetic neuralgia, this treatment can be difficult, but we do have some options. Treatments include topical products to help with the local pain, such as capsaicin cream or lidocaine ointment. What's nice with those is that they're locally acting, so we don't have to worry about any systemic side effects in that. However, if those do not suffice, then we'll look at oral medications that are used for nerve pain, such as pregabalin or gabapentin. In extreme situations, we might have to resort to other pain medications like opioids, but we really want to have other options fail before considering that. So our best treatment course is to prevent it. That's our best option, is to prevent shingles from occurring in the first place. So our gold standard to prevent it is to get vaccinated. Obviously, a first choice for that is to make sure we get the chickenpox vaccine that is available, especially for pediatric population. We want to make sure that they're getting vaccinated so they don't develop chickenpox in the first place. And then the other option, of course, for those that have had chickenpox is to get the shingles vaccine. And we'll go into more detail with that here shortly. The other piece of information about preventing the spread of the virus is preventing the spread of the virus from people with an active shingles case to those that have not had chickenpox or the chickenpox vaccine. So in that case, we're looking at our general precautions to decrease the spread of infection, again, until those blisters have scabbed over. So with that, we're looking at not touching the rash or itching the rash, covering it if possible, washing our hands often, and then avoiding contact with those susceptible. And with that, we look at specific populations like pregnant women, young infants that have not yet been vaccinated, and again, those people with weakened immune systems. So let's look more at the shingles vaccine. There is currently one shingles vaccine available in the United States called recombinant zoster vaccine, which is sold under the brand name of Shingrix. It's been available since 2018. And this is Shingrix is a reconstituted suspension of virus antigen with another ingredient added to it to help improve the immune response. So this is an inactivated vaccine, meaning that it's not active virus, so you cannot develop chickenpox or shingles from the vaccine itself. The vaccine is given via intramuscular injection, so very similar to most of our other adult immunizations, including the flu vaccine. And it's given in a 2-dose series, where the second dose happens it's recommended to happen 2 to 6 months after the initial dose. However, if you got your initial dose and didn't get your second dose within 6 months, you don't need to restart the series. The recommendations for those that didn't get their second dose within 6 months is just to get it as soon as you can. And that will get you the immunity that we're looking for. And it gets you to complete that series. Shingrix has been found highly effective in those vaccinated. In people with competent immune systems, the vaccine is over 90% effective for at least 7 years. And the reason why we say at least 7 years is because that's what we have data for. As we learn more about this vaccine, as it's out longer, hopefully we'll be able to continue to extend that time that it's available. Even in those with weakened immune systems, it's still found to be 70 to 90% effective in preventing an outbreak of the shingles. And the other thing that's nice with this vaccine is, since it's an inactivated vaccine, is it can be administered with other vaccines as well. So it's a great opportunity to get the vaccine when you're getting another vaccine, like a flu vaccine or any other vaccine for that matter. I do want to note that there was another shingles vaccine that was originally available called Zostavax. This was a live attenuated virus that was introduced in 2006. And it was the only option that we had for shingles prior to the introduction of Shingrix in 2018. What we found is that over time, we learned that the Zostavax was not as effective or long-lasting as we had hoped, and not as effective as Shingrix. So when Shingrix became available, all of our vaccine recommendations switched to making Shingrix the preferred vaccine. And that led to a drop-off in demand for the Zostavax to the point where it was eventually removed from the market here in the US in 2020. So it's no longer available, and shingles is the only vaccine that we have available to us at this time. So who should get the vaccine? Well, our current US vaccine guidelines recommend Shingrix for everyone age 50 and up. This population is most likely to have chickenpox and be most susceptible to shingles. This includes those with a previous case of the shingles. Anyone that's unaware if they've had chickenpox, just because, again, it's very likely that they have, even if they can't remember or don't think they had it. And if they've received the chickenpox or the Zostavax vaccine in the past, they're still recommended to get the Shingrix vaccine. A more recent change to the guidelines that just happened here in 2021 is that the Shingrix is now recommended for those age 18 to 50 that either currently have or will have a weakened immune system. So this could be caused by having a transplant and taking anti-rejection medications. They could be receiving treatments for cancer or other autoimmune and inflammatory conditions. So if someone knows that they'll be having treatments upcoming or that, we can adjust things and get them their doses before they resume treatments. And we can move up the schedules a little bit too if we need to. There are a few contraindications for the shingles vaccine. Those that have had reactions to vaccines in the past or a reaction to Shingrix, obviously we don't recommend getting another dose. People that are currently pregnant, and as well as those that have an active case of the shingles. Moderate to severe illness is we weigh the risk benefits kind of on that. What should I expect when I get vaccinated? The side effects of the Shingrix vaccine are very similar to most other vaccines, and that the most common ones are very short term, lasting just a couple of days. This includes some pain where the injection occurs. You might see some redness or swelling, development of a mild fever as part of your body's natural immune response to the vaccine. I have heard that, the reports patients talk about how the vaccine does sting a little bit more shortly after injection than like a flu vaccine, but it's not horrible. It's just something for people to be aware of. Our rare and serious side effects, again, are very similar to other vaccines as well, where we can have an allergic reaction. And then there is a chance of Guillain-Barré syndrome. The thing that I want to note about that is that there's a risk of that even with just developing shingles itself. So definitely want to get vaccinated with that, even if there's concerns over that. How many people have been vaccinated for shingles? So how are we doing with our vaccination rates? The answer is we're doing okay, but we could be doing better. So the green line represents those individuals age 50 and older in North Dakota that have received at least one dose. The brown dose represents those that have had the full series. And then the blue line across the top is the reported US average in 2020 for those that received one dose, at least one dose. So we were a little bit behind the US, but now we've caught up. There were some supply issues with Shingrix between 2018 and 2020 or so. There was so much demand that we had a hard time keeping up with supply, but that's been resolved now. So hopefully that will help these rates continue to increase. And we have met the Healthy People 2020 goal, which was 30%. So that's a nice accomplishment in that we met our goals with that vaccine. I'm briefly going to just show a couple of charts here with a county by county breakdown at the end of 2022, how our rates were for those receiving one dose. And we're going to focus on giving kudos to those counties that are performing very well. So excellent job to Cavalier County and Lemoore County. They are really doing a great job with their rates. We have some opportunities for improvement in the western part of the state with our rates. This map shows those that have received the complete series. And again, it's a fairly similar rate to those, or similar pattern to those that have received one dose. When we look at demographics, we see that a larger proportion of females have gotten at least one dose. And when we look at some racial and cultural characteristics, we can see that American Indian and white race have higher rates than other minorities, including Asians and African Americans. How do we get more people vaccinated? I think there's a few. I'm going to focus on 3 of the main things that are listed on this slide. The first is that we can co-administer Shingrix with other vaccines. So if someone's coming in to get a flu shot or a pneumonia shot or a tetanus booster, that's a great time to also screen for the need for the shingles vaccine and to get that first dose started at that point in time, or check to see if they need their second dose and get that done. The second one is that middle one about reminding people. So some things that we do in my practice is we'll do follow-up calls 2 months after the initial vaccine's been given to get that second dose scheduled. We'll also try, we might send some text message reminders as well. We've also, an option is to schedule that second dose right away at the time of the first dose and then give a reminder call when that appointment's coming up. The final thing that I've had my pharmacy student working on at my practice site is doing some messaging to those that have not received their first dose of the vaccine but qualify. And we've been sending out some text messages to those age 65 and older and been getting some response to that. And a lot of that has to do with a new development about overcoming cost barriers. So the Shingrix vaccine, one dose costs around $200, and this can be a barrier, but we've seen improvements in the coverage of the vaccine, especially for those with Medicare. Shingrix is a Medicare Part D, or the drug coverage covered vaccine. So depending upon if someone was in their deductible phase or not, they could have a high out-of-pocket expense that was a barrier for some to get the vaccine. Well, starting this year, there's no cost sharing for the Medicare covered vaccines. So there's zero copay for these individuals. So this is a great opportunity to reach out to our Medicare population to inform them of this change that came about as part of the Inflation Reduction Act. And so this really will open that door, I think, for those age 65 and older that haven't yet been vaccinated. For those that aren't yet Medicare age, we're seeing more and more uptake of coverage for those age 50 and older on private insurance plans, and it is also covered by Medicaid as well. Okay. As we saw, there are some issues with our vaccination rates in different demographic populations. So we can also work to educate those patients and to try to address some of our social determinants that might be involved with those groups around access. So with that, I'd like to turn things over to Bev to share her story, and then we can jump into some questions.
Well, that would be wonderful. Thank you for having me, and thank you for listening to my story. My experience is really pretty simple and pain-free compared to many stories that people have had about their experience with shingles. But I'm one of those unlucky few that got shingles after I got my vaccines. I got both vaccines, the Zostavax as well as the Shingrix, and I got shingles twice after those. So why would I be here promoting getting your shingles vaccine when I've had such bad luck? I first experienced shingles when my parents suffered and struggled with it. My dad was in his 70s when he got shingles across his forehead and near his eye and into his hairline. He had the blisters, the pain, the burning, the itching. And even after the rash itself had faded, he had all of that residual nerve pain, and it went for months. He was really miserable with it. A few years later, my mom, who was a widow by then and living alone, broke out across her back, down her back and shoulder blade, down her arm. And because she was alone, it made it very difficult for her to deal with that rash. And her clothing was so irritating. She too spent a long time afterwards with residual pain. So when the opportunity came for me to get my vaccine, the first vaccine, the single vaccine, I got it, and I was thankful that I was going to be done with shingles. Move forward a few years, and I woke up one morning with a rash across my cheek and up kind of close to my eye. I wondered what I was reacting to. I thought perhaps I was reacting to something I'd gotten into when I was raking the yard the day before. I put makeup on it, went to school, wasn't really too worried about it. By the next morning, it was much closer to my eye, and it was blistering. So I called and made an appointment with my PA. I got in after school that day, and he took one look at me and he said, "Oh, you've got shingles." And I said, "Impossible. I've had the shingles vaccine. How can I have the shingles?" And then he reminded me that it was only 50% effective. And I said, "Well, that's stupid, because why would I get a vaccine that's only 50% effective?" He reminded me that for the 50% in that lucky group that don't get shingles with the vaccine, they're free and clear. I was in the unlucky 50%, and I got shingles. But the good news was I would probably have a mild case since I'd had the vaccine. He was right. I was better within a week and a half, and there was no residual pain. There was, other than a couple discolored marks for a couple weeks, I really had no trouble at all. It was a piece of cake. Later, my PA informed me that I had the opportunity to get the Shingles vaccine, and that it was 90 to 97% effective. And so I jumped at the chance again. I ventured out in the middle of a pandemic in 2020 and got both my vaccines. And at 97%, I knew that I was done with shingles for good, except I wasn't. Last spring, I had kind of a series of unfortunate events. I fell on the ice. I injured my shoulder. I ended up getting rotator cuff surgery. From the antibiotics I took for surgery, I ended up with an intestinal bacterial infection, got really sick, got that under control, relapsed, ended up with 5 weeks of antibiotics to try and get it under control. And my immune system was, wrecked. I was really not well. And then add to it the anxiety and stress of worrying about getting a third relapse or a third infection. I was really not feeling very well. And then on a fine July day, I thought that there was a seam on my blouse that was irritating my arm. It was itching and burning. And so when I went to investigate, I could see the blisters and I could see the rash, and I knew shingles. Made an appointment the next morning, saw a nurse practitioner. She verified my diagnosis, and then reminded me again that because I'd had the vaccine, I was very likely not to have a severe case. I didn't even get another blister after that. I did break out a little bit on my wrist, but that didn't even blister. Within 2 weeks, other than some skin discoloration, I was well. So that's why I'm here. I'm here to say that if you are in that lucky 90 to 97%, you get your vaccine, you are in that 90 to 97% group, you won't ever have to suffer with shingles. If you're unlucky, like me, in that 10 to 3% group, you are very likely to not have a very serious case, and it will be a piece of cake for you. So that's my story. That's why I'm here to really promote getting your shingles vaccine. Thank you.
Thank you so much for sharing. So we can move, we have quite a few questions. We can move into the questions. We do have one just that came up after your story, Bev, and Dr. Steig, maybe you can answer this too. Is there a genetic component that makes like your family more susceptible? Is there, do you know?
That's a good question. My answer is not that I'm aware of. I think it's the reverse lottery is what you've hit there, Bev, and that you're getting the bad luck with these odds here. But it's good that your case wasn't as severe because you had been vaccinated, so that's great. A reminder that 50% of people that get to reach the age of 85 are going to have developed shingles. And so I don't know that it's a genetic component. It's just the fact that we have a high incidence the older that we get.
And both my parents were in their 70s when they got it. I was over 60 for my first case and almost 70 for my second. So I mean, age, I think, is much more a factor than genetics.
Right. So let's move to another question. Should people who have a history of getting shingles but are younger than 50 get a shingles vaccine?
That is a good question as well. We got some great question askers out there today. So the answer to that is that at this time, as we know, vaccine recommendations can change, but at this time, it is only recommended for those that are immunocompromised. Now, for those that are between 18 and 50 years of age. So if they have a competent immune system and they still develop shingles, that is going to be a very rare situation. So if someone has developed shingles or multiple times and they're under the age of 50, I would guess that in the majority of those cases, there's going to be something that is causing them to have a weakened immune system, which would then qualify them for the vaccine.
Okay, thank you. Another question is, if I get the shingles vaccine when I turn 50, will I need a booster later in life?
That's a tricky one. And again, the answer at this time is no. It is not recommended. Right now, our current guidelines are just to get those 2 doses in the series. Now, with that being said, we know that Shingrix is effective, 90%, at least 90% effective for at least 7 years. 10 years from now, when we have more data, we might identify a need. I don't have my crystal ball to know what's going to happen with that. But at this point in time, it looks like this vaccine is going to be highly effective for a number of years, which will reduce the odds of us at some point in time needing to have a booster.
Okay. And so if you've had shingles and the latest vaccine, the odds of getting shingles are, what do you think on that question?
The odds, so if you've had
shingles and you've had the latest vaccination series, what are the odds of getting shingles again?
The odds of that are very slim. It's Bev odds, I guess, is kind of where we're at with that. So we have about a 4% recurrence rate of shingles in the first place. So if you have shingles once, you got about a 4% odds of developing that again. With the vaccine, they have found that it is, again, in that 90 to 90% effectiveness range for preventing a second case. So you're taking 90% of that 4% risk away. So you're bringing that risk way down.
Okay, thank you for that. Is there a way to reassociate the word vaccine with health and wellness? What have you seen work?
That's a good question. I'd encourage others to enter comments if they've seen that in their practice. We will often refer to the vaccines as preventative and wellness. So kind of along the phrase of that question is that we can do that. So we can say, hey, as part of your wellness review that we're doing here, or looking at your preventative needs, this is something that we've identified. And then we can discuss the vaccines along with other items that we've identified. Obviously, making the screening part of our annual wellness visits and things like that will also help to associate that vaccine with health and wellness.
Okay, and it might tie into this next question, but what verbiage is used to encourage hesitant people to vaccinate?
Yep. So with that, I always tell people specific to the shingles vaccine, as I kind of tell them what Bev stated, and that what I have heard from patients that have had shingles is that it's something they don't wish upon anyone else. It's not an enjoyable experience. They would rather have not gone through that experience at all. People that have had shingles are the greatest advocate for getting the shingles vaccine. So that's kind of the way that I work to address that type of question with hesitant people, is that the risks of the shingle vaccine are much, much less than the risk of the complications of having developed shingles, especially shingles when you haven't been vaccinated, to even have a lesser case of it. I don't know, Bev, do you have suggestions on that one?
Well, what's interesting is that I can hardly have a conversation with anyone about shingles and them not know of someone who's had a really miserable case. And so I'm surprised that people are hesitant when they have personal experience with friends or family members that have had it. I had lunch with someone who could be my daughter. She's in her 50s, who had shingles, and she suffered with that residual pain for up to a year afterwards, and said, if she had been able to get the vaccine and avoid all of that, she would have done it. So I don't quite understand the hesitancy. It's an easy vaccine. I didn't get sick when I got it. I've watched someone go through shingles. I would never want to do that and get as sick as they did.
Thank you for that. So our next question is, so this person was recently made aware that Shingrix is available for 19 plus immunocompromised individuals, and would like to work with the Ryan White coordinator to see if clients would want it, but was curious if there were any single page handouts specifically on why immunocompromised populations should receive it. Do you have any information on that or resources?
From what I have seen in some of my own research to try and find those types of handouts is, obviously the first thing I would recommend is the VIS, the vaccine information statement that's available for all vaccines. It's not specific to the immunocompromised population, but it does address that, as well as the need for those age 50 and older. Since this has been a relatively new change to the guidelines, some of the patient-facing education that's available out there, to be honest, hasn't been updated yet. So if you have materials, you'll want to double check that to make sure that they have been updated. I have found immunize.org has some good Q&As in that on the use of the shingles vaccine in the immunocompromised population. So I would use that as a reference. Not all of their materials are easily printable. You know, they're more in a web format than a print format. That would probably be where I would say I found the best information on for patient-facing information for using an immunocompromised population.
Okay, thank you. Next, since the varicella vaccine is a LAV, even though the recipient of the vaccine did not get chickenpox, can they get shingles?
It's not as likely, but I believe there is a small chance of it. So that is why that group is still recommended to get the shingles vaccine. This will be something that, again, I think we're going to learn more information over time because the chickenpox vaccine, the varicella vaccine, did not become available until the late 80s. So the pediatric population that got that vaccine hasn't hit the high risk for shingles criteria yet. You know, that population hasn't hit the age 50 or higher. So it might be something where we'll learn more over time. But at this time, that's why we are recommending it, even for those that got the varicella vaccine, just to make sure.
Okay, thank you. Another one, can the attenuated virus from the vaccine lie dormant, then eventually cause shingles later in life? Do we know that yet?
Yeah, that's basically the same.
Yeah, it's the same question, I think.
Yeah, except, well, attenuated. The varicella vaccine for kids, is live attenuated. So that's basically the same question. Yep.
Perfect, thank you. And then we had one more come in here. Do you use the varicella zoster titers to judge if an immunocompromised person should receive an additional dose at a later date?
Right now, I'm getting some feedback here. Right now, for immunocompromised patients, it's still just the 2-dose series is recommended. So there's no additional dose after that, even in those patients that are immunocompromised. I hope that addresses that question.
Okay. Sounds good. Thank you for that. Let's see here. I think I'm going to share my screen now, and we will continue. One second here. Technical difficulties on my end. Okay, can you see my screen now? Sorry about that. All right, so I don't see any more questions coming in. So thank you so much to our presenters and for taking the time to be here today. Looks like are you sharing your screen, Dr. Steig? I feel like my slides aren't going.
I don't know. I will stop my.
Okay.
See. No, it does not look like I'm sharing. So.
Okay. Perfect. Let's try this again then. I don't know what's happening.
It's Gremlin Day today with technology.
I guess, my goodness. All right, here we are. So yes, again, thank you everyone for attending, the wonderful questions that you had. It really just makes the conversations flow so well. And thank you for answering all of them, Dr. Steig. To stay connected with us, you can follow Healthy NODAC on Facebook, Instagram, and Twitter, and Foundation for Healthy North Dakota on LinkedIn. Also, to join the coalition, visit the link to stay aware on future webinars and updates on the foundation. And lastly, please scan the QR code if you're able to complete the evaluation survey. We will also include a survey link in the follow-up email you will receive after the presentation. So thanks again, everyone, for joining, and have a great rest of your day.